Hi, everybody. Good evening, good morning, good afternoon, wherever you are. A very warm welcome to all of you. It is 6 p.m. in Paris, 5 p.m. in London, 11 a.m. in Houston, and 11 a.m. In Iowa City. It is my great pleasure to welcome you to this new broadcast, this new journal club, brought to you by the International Academy for Clinical Hematology, the IACH, around the globe and across the hematology field. I'm Mohamad Mohty from the Sorbonne University and Saint Antoine Hospital in Paris in France. And it is always a true delight to moderate this twice monthly journal club of the IACH. Today, selection for this journal club is a recent publication in the Journal of Clinical Oncology by Dr. Naval from MD Anderson in Houston. He is the first author and he is our guest panelist today. Thank you, Naval, and good morning, and thank you for joining us.
Thank you, and good morning, and thank you very much for having me. Looking forward to this discussion as usual with you, Mohamad and Prajwal.
Thank you. Always a pleasure having you with us, Naval, and you are a big fan and supporter of the IACH activities, and I'm very grateful. And our second panelist, and by principle, he's not a co-author of the work, but he's an expert in the field, and this is namely Dr. Prajwal Dhakal, who is an assistant professor at the University of Iowa, and his field of expertise is about myeloid malignancies. And the title of the paper that was chosen by the steering committee is Tolerability and Efficacy of the Anticluster of Differentiation 47 antibody Magrolimab combined with Azacitidine in patient with previously untreated acute myeloid leukemia, phase 1b results. And we'll hear it from our panelists, but there's definitely tremendous excitement about antibodies targeting CD47 in myeloid malignancies. Here you can see the abstract of this paper. So it's a phase 1 trial, so it is a sort of a proof of concept looking into the safety. And most importantly, it is not used as a single agent, but also in combination with Azacitidine. And this is about a population of AML patients who are considered as ineligible for the classical conventional intensive chemotherapy. Another important piece of information is that among these 87 patients who were enrolled and treated, the majority actually had a TP53 mutations. And this is an important piece of information because we all know the very dismal outcome of these patients. And today I consider, and I'm convinced that this is still a big unmet medical needs, a subgroup of patients. And the conclusion of the paper was about the promising efficacy in this population, including in these hard-to-treat patients. And I think we'll speak about this in the conclusion. It serves as a basis for phase 3 randomized trial. Here you can see some of the characteristics of these patients who were included. Up to age 89, median age 73. So definitely these are patients with advanced age. There are patients who are Black, African American, Asian. And this is, I believe, very important in terms of improving the diversity among patients included in clinical trials. 14% had an ECOG performance status of 2. And last but not least, and I'll not go into the details, they are very well explained and described in the paper, 69% had an adverse cytogenetic risk category. Jumping now to the efficacy endpoint, actually you can appreciate that the overall or objective response rate was around 47%, including 32% of patients in complete remission. Again, for the sake of time, I'll not go into all of the details. And the median duration of CR was actually, in the overall population, a little bit less than 10 months, but then you can see it was 31 months in the TP53 wild type and 7.7 in the TP53 mutation group. So really interesting piece of information. Here you can see the probability of remaining in CR depending on whether or not the patient are from the TP53 mutant versus wild type groups. And if you look to the overall survival probabilities, and this is going to be part of our discussion, you may interpret this as the glass is either half full or half empty. But again, I do kindly remind you that this is a phase 1 trial. And the knowledge generated according to the JCO editors is summarized here, that this combination is generally well tolerated. The hematological toxicities like anemia are expected in this field, and definitely that can pave the way for further investigations, but also maybe using this kind of combinations as a bridge to allogenic stem cell transplantation. So I'll stop here and welcome our two guests, Dr. Dever and Dr. Dhakal. And by the way, I would like to remind all of you, so this is being broadcasted live, that you can interact with our panelists. You can post your questions, your comments, your suggestions. You can disagree, you can agree with the panelists, and I'll do my best to moderate all this. So as usual in the Journal Club, first question goes to our guest, who is not a co-author. So the first question is for you, Prajwal. And before digging deeper into the paper, maybe because I'm not sure everybody is familiar and knowledgeable in the role of this target, the CD47, in myeloid malignancies. So if you can summarize the role of such target and why is it important to develop antibodies agents targeting CD47, please.
Sure. So first, thank you for having me. And I would like to congratulate Dr. Dever and team for doing this study, really good study. So, so as Dr. Mohty said, some introduction about Magrolimab. I'd like to start with CD47. So it's usually elevated in all the leukemic cells, or most of the leukemic cells. So that's because of that, we've looked more into this. And in the preclinical studies, what we have found is CD47 expressed high in leukemic cells, and CD47 SRPP alpha, SERP alpha. So it goes together in the axis, which kind of controls the destiny of tumor cells. So it has this don't eat me signal, basically saying macrophages to not eat them. And that's what we're targeting. Once we target that, it goes into like eat me signal, and that attacks the tumor cells. So that has been the basis of using this targeted therapy. And again, as any targeted therapy, our goal is to minimize side effects, go ahead with more efficacy, and that's been the main thought process, I would say. And from what we know, azacitidine also has some effect on that axis, and can increase the effect of CD47 antibody. And I will let Dr. Dever delve more into it, but that's been the thought process with using this. And again, Magrolimab.
Yeah, please.
No, I was just going to say that's been the whole thought process of using Magrolimab, and we're very excited, and we do have some promising results here.
Thank you very much, Prajwal. So this is very clear about this eat me or don't eat me signal. So my question to you, Naval, is about the combination, actually, the rationale behind this combination. Of course, I'm sure everybody is quite familiar with the role of hypomethylating agents in myeloid malignancies, and they have been around now for more than 15 years. And we would love to see things beyond, I think, the role of azacitidine or Azacitidine. So can you just explain to us the rationale behind these combinations? And by the way, I think there are also different antibodies against CD47 being developed. Magrolimab was tested in this protocol, but there are other being tested by different companies, I guess.
Yeah, no, absolutely. And I think, Prajwal gave a very nice biological overview of the mechanism of action of these CD47/SERP alpha inhibiting drugs. So it's important to know that these are a very unique modality of harnessing the immune system, especially the innate immune system. A lot of the work that has been done in the past with immunotherapies has been focusing on the adaptive, which is the T cell immune system, immune checkpoints, PD-1, PD-L1, CTLA-4, and we did a number of trials with those as well in myeloid diseases. And unfortunately, except for the post-transplant, especially extramedullary population, we did not see as much activity has been seen in lymphomas and solid tumors with the adaptive immune system. So here the idea is to engage a different component, which seems, based on preclinical work as well as animal models, to be more important in myeloid diseases, the macrophages, NK cells, dendritic cell, innate immune component. Now, the reason for the combination is actually based on preclinical work that was done by the group at Stanford, Ravi Majeti, Mark Chow, Irv Wiseman, some of the pioneering, well-known scientists in this field of innate immunotherapy, where they actually showed that the use of not just hypomethylating agents, but also actually with intensive chemotherapy as well as potentially targeted therapy, you cause cell death. And that cell death then results in increase in certain markers called prophagocytic markers. One of them that is well known and was looked at in their analysis was calreticulin, but then there are others as well, such as phosphatidylserine, SLAM7. And so basically increasing these prophagocytic markers along with blockage of the antiphagocytic signal that comes through the SERP alpha CD47 kind of gives a double hit. So you block the don't eat me signal, and then you create a eat me signal with prophagocytic marker expression. And that is why they felt in their preclinical data that was published in Cancer Cell showed a synergy with this HMA approach. And then, as you said, Mohamad, of course, HMAs on their own already have a standing and activity and are already approved in the frontline setting for high-risk MDS as well as certain high-risk AML subsets, which led to the logical as well as preclinical data supporting this combination, especially for the high-risk groups where HMAs alone do have responses, but the benefit is much more limited.
Excellent. Thank you very much, Naval, for this very clear explanations, and the science behind this is really very strong. So let me move now to the clinical data, Prajwal. And first, what is your thought on the group of patients that were included? I felt that these are really, really very, I would say, hard to treat patient. And then the other question, of course, is when you saw the results, do we consider this like a wow effect, or is it work in progress?
Yeah. So as you said, very good population, I would say, especially because, again, TP53 mutation, we have 70 plus 72 patients. So that's very hard to treat, basically worst prognosis AML type. And when you look at the characteristics of patient population there, I would say, again, being only 15 patients in the other side, it's kind of hard to look at the exact percentages, but again, pretty similar, I would say, with the characteristics part. But in terms of TP53 mutation and adverse cytogenetic risk that goes with the mutation itself and other cytogenetics, I would say, again, hard to treat people, I would say, yeah. And the other thing I was looking up, again, the patients who do have transfusion dependence, also platelet, I mean, both with RBCs and platelets, and pretty good allele frequency if we're looking at that as well. So pretty good population. Again, looking at the results itself, I mean, wow results to some extent, but also promising. This being a phase 1b study, it's a little hard to say exactly. But again, good CR rate of 30%. Similar kind of overall response rate with both population, and again, little more with wild type population, but still TP53 mutated patients did have overall survival of around 9 months. We know that with other treatment, it comes to like 5 to 7 months. So pretty good response there, I would say, as well.
And thank you. Yeah.
No,
sorry.
Go ahead.
No, I think definitely we are in agreement, and I thought maybe to ask Naval, because you've been running many of these phase 1 trial, different combinations. Some drugs unfortunately never made it. So you've treated a lot of these patients. What was your feeling about this regimen? Was it really well tolerated? Because 30% CR rate is not so bad, and it could be obtained like after 4 cycles, which is again relatively quick. So what is the tolerability, feasibility, acceptability by the patient?
Yeah, I know, absolutely. I think, and I think it's really important always to highlight that this is a phase 1 study, and by definition, many of these are done at large academic centers with a lot of logistical support, expertise, transfusion capabilities, right? And that's always been the challenge in not just AML, but also in ALL, MDS, myeloma, is to translate findings that you may see in centers with a lot of expertise and support to larger groups in 100, 150, 200 centers across different regions and countries. Now, in our experience, this regimen was actually very well tolerated. We have treated close to 150 to 180 patients now with different Magrolimab-based combinations across different phase 1, phase 2, phase 3 studies. And I really think that among the different combos we have done, you know, as Dr. Mohty says, combos with venetoclax, with FLT3 inhibitors, triplets, this is probably one of the easier combinations in general to deliver. That being said, the most common and important side effect to be aware of is the anemia. This happens usually early on within the first 7 days for majority, 90% of the cases. And this is actually an on-target anemia because CD47 is very heavily expressed in the RBC cytoskeleton, and especially the older RBCs, when they're bound by CD47, they get removed by the reticular endothelium and the splenic system. And so you get an early clearance of old RBCs tagged by CD47. And then over 7 to 8 days, these are repleted with younger RBCs that do not express as much CD47. So I think just awareness of that anemia, and in our center, we get a lot of patients who come from, 400, 800 miles, different states. So sometimes we would admit those patients for 7 to 8 days just to get a close monitoring, daily labs, transfusions aggressively. And the median hemoglobin drop is not very high. It was about 1 gram, which is usually manageable. But what's important is not the median, it's the outlier. So there are about 8 to 9% patients who could have a 2 to 3 gram drop. And now imagine if you have a 80-year-old with AML or MDS with a hemoglobin of 8.5 and you have a 2.5 or 3 gram drop, this is going to put the patient at high risk of cardiac pulmonary issues. So I think we were aware of this early, and we kind of addressed this aggressively, just as, for venetoclax, we would do with TLS or menin inhibitors differentiation syndrome. Every new drug, there's a unique management profile. But yeah, once we did that, actually, the long-term tolerability of this regimen was actually really, really high. So once you get beyond that 10, 12 days, we did not see cumulative neutropenia, thrombocytopenia, for example, that you see with venetoclax. Cycles usually could be given every 4 to 5 weeks. There was not much GI, cardiac, hepatic, renal issues at all. So really quite manageable in our experience. Yeah.
No, thank you very much, Naval. And actually, you anticipated the question of Dr. Alberto Salinas Rodriguez, who is a very loyal follower of the ICH activities, who was asking about, indeed, how to take into account the impact on red blood cells, because CD47 is well expressed on red blood cells. So thank you, Alberto, for highlighting this. So here I'd like to switch a little bit into the combination by itself. And my question to you, Prajwal, and I may be wrong, I guess that in the non-intensive treatment eligible patient, the standard of care is usually more AZA plus venetoclax. Please correct me if I'm wrong. What is your practice, Prajwal? And then the question to both of you, how do we view venetoclax in this scenario of having an anti-CD47 plus AZA? Because obviously, 3 is going to be probably more toxic than 2. We're going to be more like intermediate intensity or even maybe intensive. So what are your thoughts, Prajwal? What's currently your practice, and how do you envision things in light of this trial?
Yep, as you said, we do go for SMA venetoclax combination for TP53 mutation. These days, it's been a little hard with overall prognosis and them getting into at least some kind of premise. And if possible, we still would think about transplant in those patients if they go into minimal residual disease negativity and are doing well overall. That's been the best treatment plan. If the patient is old and not that eligible for transplant, then again, first goal, MRD negativity. It's been a little hard with a couple of cycles, but mostly after 3 or 4 cycles, most of them go into it. It's again hard to maintain that for a long time, but that's what we're doing these days.
Excellent, thank you very much. So Naval, in this protocol, these were patients who were relatively frail and not eligible to transplant. Do you have patients who were able to be bridged to transplant? And what was the outcome?
Yeah, and we kind of discussed that as well in the manuscript. We did have, so just kind of a background set as to what Prajwal is mentioning as well, right? We do actually have very good prospective data with HMA-VEN, and actually now recently data on different molecular subset outcomes with HMA-VEN. I think this is really important and helpful as we develop these new agents, combinations, whether they're doublets or triplets, because HMA-VEN is good, it's effective, but we do know that 3-year survival is 23%. This was just presented at ASH by Keith Pratt's 2022. So really, this is not the end of the road. It's kind of the beginning of the research is how we see it. And we need to build on this, maybe akin to an analogy of Revlimid Dex in myeloma, where you now have a good backbone. But of course, this is not sufficient to get 70, 80% long-term survival yet. The other thing is there are certain molecular subsets that do really well with HMA-VEN. So NPM1, IDH1, IDH2, you could have close to 85, 90% CR, CRh with 3-year survival, almost 60, 65%. This was shown by Donor and colleagues in a molecular analysis of the VIALE-A study, proposing a new prognostic risk score for VIALE-A. But then there are the difficult players or the bad actor mutations, which include TP53, FLT3, and RAS. And TP53 really is the hardest one. So in the VIALE-A as well as the phase 1b, we know that the response rates were low, about 30, 35%, including CR, CRi. True CR rate was only about 20%, and the median survival was 6 months for TP53 mutated with HMA-VEN. So I think that is kind of the ground setting, as Prajwal mentioned, that we need to look at when we start developing drugs in TP53. And it'll be very different if you're developing something in IDH and NPM1, where the medians are already 28, 30 months. So I think that's just important that we don't look at HMA-VEN as one large homogeneous bucket. You can have very diverse outcomes. The second is transplant rates were seen. We had about 10 patients, if I recall, who made a transplant out of the 80 or so. So close to about 10 to 12% transplant rate, which is kind of similar to what we saw in the phase 1b single arm Aza-VEN study that Dr. DiNardo, Poli, and others did, where we had about a 10% transplant rate. These are usually patients who are a little bit on the younger side, closer to 70, 68, 70, 72, where transplant, as you know, is now being considered more and more frequently in large academic centers, and patients, especially with TP53, who are below 74, 75, we would routinely consider transplant. So some of those were our patients. There were some at Moffitt with David Salmon, who was the co-PI and enrolled heavily on this study, and then a few others. And in fact, as expected, getting the patients into a remission, whether it was a full CR or a CRi, and then going to transplant, definitely was the best path, where the median survival, even in TP53 mutated patients, was pretty prolonged, with a 1-year survival of about 70%, 2-year of 60%, which is very good for TP53. So I think whether it's with the Magrolimab or whether it's with other approaches, the focus here is really to get the TP53 mutated patients into remission and then to transplant, but critically to not have a high early mortality. Because with TP53, what we have started to learn is it's not just the lack of efficacy and response that actually leads to mortality. It's also that these patients seem to have a very deranged tumor microenvironment, a very weak immune system, and a lot of the mortality happens early on within the first 30 to 60 days, even before response assessment. So intensifying therapy is unlikely to be fruitful. This has been tried with very intensive chemo regimens. So the question is, can you find low intensity therapies that work through novel pathways without adding significant cumulative neutropenia, immunosuppression, allowing a good transition to transplant? I think that was one of the efforts here, and something we're looking at with other drugs in the same TP53 space.
Excellent, thank you very much, and this is very well taken. Okay, we already answered one of the questions from Dr. Andreas Suneska about the outcome of patient bridge to allo. There's another question about what would be the optimal combination based on these results. And I mentioned venetoclax, and both of you commented on this. But I think Dr. Garcia Manero from MD Anderson published in a few months ago, I think it was in April, Lancet Hematology, another phase 1 trial focused on these TP53 patients, where he used actually eprineta popped. I hope I am pronouncing it correctly. It's always a difficult drug. This is an APR-246, first-in-class small molecule PP53 reactivator. And they evaluated the combination of this drug, eprineta popped plus venetoclax, with or without azacitidine. So my question here would be, is there a room for actually this TP53 activator and Magro plus whatever AZA or venetoclax. Any thoughts from both of you? I don't think it has been done, but
yeah, I mean that is obviously a proposal and something that many of us, David, Salman, myself, are interested in. The logistic hurdles, of course, with that is the APR or eprenetopopt. Unfortunately, did not meet the pre-specified statistical endpoint of the study in MDS, which was a phase 3 frontline randomized study in patients with TP53 mutated high-risk MDS. Now, that being said, there was a numerical advantage. The true CR rate was 33 versus 22%. So again, your analogy of glass half empty full, I think, is apt, because that's a 50% absolute increase in a true CR rate, not marrow CR, CRI, PR, which is pretty meaningful. But the study, I think, was underpowered, a little bit overambitious based on the phase 1 data. And so in the end, the p-value was 0.10, fell short of the mark. And so this has, of course, slowed down the development, and the future is unclear for the eprenetopopt at this time. If there was a way for it to be developed further, I think looking at a combination with the CD47 antibody, whether Magro or others, would make a lot of sense. And then also very nice recent data that you may have discussed at IACH, looking at maintenance post-transplant with the eprenetopopt, published in JCO also a few months ago, showing really dramatic 28-month survival post-transplant in TP53 mutated AML MDS going to transplant. So I think if we could get it, that would make a lot of sense. Other combinations I think that one could think about are obviously whether there's a role to combine this with Aza-Ven as a triplet combination. Preclinical data from Marina Konopleva, shown at ASH last year, did suggest that the combination of the 3 drugs had the highest prophagocytic markers and synergy both in TP53 mutated and TP53 wild type PDX. And then potentially could there be a role even to combine it with intensive chemotherapy, because the prophagocytic markers are increased not just by the HMA, but also by the chemotherapy. So I think these were are the 3 potential additional combination partners that one could think of.
So Prajwal, almost same question to you. Based on these results, and if you have access to different type of new agents and you have the sources, what would be your ideal combination that you would like to test in the same population, actually, to further improve these results?
Yep, I would kind of a little bit add to what Dr. Dever said. Based on what we have seen till now, eprenetopopt does need to be in combination. It just by itself may not be the best option. But saying that, the results from the latest study that you talked about from Dr. Garcia and Manero, some promising results there. Again, being a phase 1 study, it's hard to say how good it was. Pretty well tolerated in that case. Again, triplet regimen with azacitidine, venetoclax, which we use all the time. So definitely one thing to look more into. But being said that, again, should we combine that with newer drugs like, again, Magrolimab or other antibodies or something else that we could look in down the line? But at this time, based on what we've seen, intensive chemotherapy, even if it cannot be very intensive, some dose adjustment and doing that with the combination, again, same with Aza-Ven. I think some kind of combination will need some kind of adjustment with dose and side effects and all those things, but definitely something that we should look more into and look into combination with new drugs as well, not just CD47 or this chemotherapy.
So speaking about CD47 and targeting CD47, Naval, do you see any differences between the different agents being developed by different companies, or this is just about Me Too drugs?
No, actually big differences. And I always like to, look at the analogy of JAK inhibitors, for example, or FLT3 inhibitors. many people may or may not be aware that there were 12 JAK inhibitors that went into development between 1990s and early 2000s, and only one of them, ruxolitinib, at that time had the right safety efficacy profile to make it. Now, recently, yes, in the last 4 or 5 years, we've had others. And the same with FLT3 inhibitors. The first FLT3 inhibitor that was tried, many who are fellows and younger may not remember, but lestortinib actually was negative. The study was completely negative. Many started questioning whether FLT3 inhibition is important. Of course, now that is history, with 4 FLT3 inhibitors showing fantastic activity, but also having very different tolerability safety profiles. So we do have experience now with other CD47 SIRP alpha antibodies. These include TTI-622, which is being developed by Pfizer, both in myeloid diseases, T lymphoid diseases, as well as myeloma, as well as the ALX drug that is on hold, but also was being looked at in high-risk AML MDS. And then recently also BMS has a CD47 antibody that is being looked at, and 2 bispecific antibodies, which biologically to me are very interesting because they are trying to engage both the innate immune system through CD47 SIRP alpha anchorage, but also at the same time have T cell markers such as CD40 or 41BB CD28 to try to get a dual innate and adaptive immune response. So 2 of these are ongoing. What I can say, because a lot of this data is not yet presented, some will be at ASH and then other meetings next year, is that especially when it comes to anemia, there are quite big differences with some of these agents, as already has been shown publicly with TTI-622, which targets SIRP alpha, which is important because SIRP alpha is not expressed on the RBC cytoskeleton. It actually does not give us any anemia. So we have not seen any anemia with the TTI-622. With some of the others, the bispecifics, we have seen infusion reactions, very typical of what you would see with biological antibody-based therapies, but also have not seen as much anemia. So I think we're kind of in the early stage of this field of innate immune engagement. And I think that really the big question is it a drug effect? Because of course, we're going to talk about the Enhance 1 and Enhance 2, where we did not see as promising or as expected and hoped outcomes. So the question is this the drug effect of Magrolimab having some anemia issues that were difficult to manage, or is this a class effect of CD47 SIRP alpha? I personally feel that pathway is still very relevant, just like FLT3 or JAK inhibition was, but it may be that we need to find the right drug with the right combination of safety efficacy as we had to do for those other pathways. But I think this is going to be the important area of research in the next few years to understand better.
One quick question to you, Prajwal. Would you consider targeting CD47 as a form of immune therapy, actually? Because it looks like now in all kind of hematological diseases, we're trying to harness the immune system. It's either by, using the T cell engagers, the innate immunity engagers. Now we have this pathway of macrophage and induction of apoptosis. What is your thought?
Definitely. I think for one thing, at least from the studies till now, we do know that CD47 is a very good target. So that's been the main starting point, right? So anything we can get around it, I would say we should definitely look more into. We've been doing antibody. I think that, as Dr. Diver said, that few studies with bispecific antibodies there. And so when we look at, would this, again, same thing coming back to enhanced studies, are these drug effects, are these side effects, are they not getting enough of efficacy just because of their antibody and not as effective focus on the SIRP alpha pathway itself? So I think looking at more of those things would be helpful. Again, other drugs against anti-CD47, from what I know, all of them are not the same way attacking SIRP alpha. So in that case as well, definitely looking at other ways would be very helpful. And if we have something, definitely we would consider that. Why not?
Okay, thank you very much. One last question to you, Naval, just to clarify, because I'm not sure I understood this, and this is also a question from Professor Arnold Ganser from Germany. What is today the current status of these ENHANCE-2 and ENHANCE-3 trials?
Correct. So yeah, I think that's very important to discuss. So the ENHANCE-1, which is the MDS study of AZA magro versus AZA placebo in higher risk MDS, which is IPSS-R intermediate high, very high, unfortunately did not meet the primary endpoint, which was overall survival. Now the data has not yet been presented, published. We will next year. We're working on that. But I will mention that in this study, the anemia, which was again very manageable in the phase 1 across big centers with a lot of expertise in logistics, was more of an issue, and that will be discussed when we present the data. During that study, there was a urgent safety measure implemented by the FDA. This was about 3/4 of the way after enrollment of ENHANCE-1 MDS, which required more stringent monitoring of hemoglobin, which I think was very, very helpful and important, with the blood work to be done 6 to 12 hours after the first, second, and third dose, which is on day 1, 4, and 7, and transfusion to keep the hemoglobin above 9. So with ENHANCE-2 and 3, in fact, when the interim analysis was done at the request of the FDA after seeing the ENHANCE-1 did not meet the primary endpoint, we actually did find that the anemia signal had been mitigated to quite an extent because of the urgent safety measure and more proactive management, monitoring, and transfusion. And in fact, safety was not an issue in either ENHANCE-2 and 3. These are the words of the FDA and the DMC committee. And the reason, though, that ENHANCE-2, eventually Gilead made a sponsor corporate decision to not proceed with the completion of the trial is because they actually decided to unblind look at the survival data, and they felt, based on that early analysis, that it was unlikely that ENHANCE-2, which was all TP53 mutated frontline patients, would meet the pre-specified delta for survival. Now, that was a very early look. The median follow-up had been 1.92 months, and we're actually going back and reviewing that data with the more mature follow-up that's actually happening right now with Gilead and many of the PIs. So hopefully we'll have a more clear picture. But as it stands today, that study has been terminated by Gilead because they, as a corporate group, felt that there was unlikely chance of success, but there was no safety concern by the FDA. The FDA did not require any action. Now, ENHANCE-3 is the study which is the one we have been most interested in, which is the triplet, the AZA-ven Magrolimab versus AZA-ven placebo, but not in TP53 only. This is for all older, unfit, VIALE-A-like eligible patients. And that study at this time is on a hold because we are waiting for updated survival. So we have submitted the data to the FDA. At this time, there were no concerning safety signals. The FDA has not requested any further action, but the DMC, which submitted the data to the FDA, wanted to look at an updated survival analysis. So they are going to re-evaluate this in the next few months and then make the final decision. About 60 to 70% of that study has been enrolled. And if we see that there is some positive signal in the review by the DMC, then hopefully the study will continue. Now, remember, all of this is blinded to the investigators and the sponsors. So this is really just based on recommendations of the DMC and the FDA. But we're hopeful that the triplet will still have a potential path forward. We will know in a few months.
Thank you, Naval, for this update. And actually, this clearly highlights how it is difficult actually to develop drugs in this space. These are hard to treat patients, very highly resistant diseases. And obviously, while Magrolimab has been facing some disappointment, I think we are fortunate, and I think you mentioned it, that there are other agents, and I think you alluded to the Pfizer agent, TTI-622 and TTI-621, who are really two great candidates that are designed to block CD47 while simultaneously delivering this eat me signal to macrophage. I think we have reached the end of this journal club. I hope everybody has enjoyed it. I do thank you both, Prajwal and Naval, for sharing your knowledge, your passion. Sometimes it's a little bit, I would say, disappointing to see some of these resistant diseases, but this is about passion, and we would like to continue to work hard all together to improve the outcome of these patients. And this is why, again, congratulations, Naval, and the whole team, and all of you guys working on these very hard to treat patients. So to all of you guys following the IACH, I'd like to say thank you for following us. Thank you for being loyal, and wherever you are, whoever you meet, wherever you go, please stay safe and keep well, and see you soon. Take care.